So it's my pleasure now to introduce our next speaker, Dr. Vani Paleti. She's a board certified gastroenterologist working with Baylor, Temple, Texas. She's a plant based nutrition coach and chef. So her interest is everything about gut health, which we all need it very much. So she is her interest in nutrition, culinary medicine, and most importantly, creating simple recipes for home cooked meals. Of course, she's a mom with two children, has other interests, gardening, photography, and hiking. She hiked Mount Kilimanjaro and she was very proud of it, and she is here to tell us all about gut health. Welcome.
Everyone. I get to talk about the fun stuff. When Dr. Gangi reached out to me saying, hey, we are putting together a culinary wellness symposium. Do you want to talk about culinary medicine? I'm like, oh, wow, yes, sign me up. And I'm amazed to see the turnout for a wellness symposium. Like, there's so much of turnout to talk about wellness and lifestyle medicine, and the speakers before me did a very good job in talking about pillars of lifestyle medicine, and I'm going to talk more about it. How many in this room have heard about culinary medicine or practicing culinary medicine? Okay, maybe around 10. That's wonderful to know. And for the rest of y'all, I'm here to talk about culinary medicine. I'm going to knowledge share. We can learn together and we can like share ideas. So my first slide, this is a beautiful Japanese concept. It's ikigai. Iki means life and gai is reason. At some point in each life, everyone's life, we reach a point where we find a reason, we find a passion, or we find a purpose. And at this stage in my life where I'm fastly going to mid-40s, lifestyle changes play a big role so that I can grow older in a healthier way. And that's my current passion and purpose. And it aligns with the ikigai of today's symposium. So that's what we're going to talk about. Talking about lifestyle medicine, the 6 pillars. We all have been talking about the 6 pillars: healthy eating, physical activity, stress management, relationships. And I think in a busy digital world, we try to communicate, but we are not holding real relationships. So connections are very important. The village to fall back, the safety net is very important, and stress management and substance of abuse such as tobacco, alcohol, excessive alcohol consumption, all those play into the lifestyle changes. So why are we all talking about this lifestyle modification? Why are we talking about pillars? It's because of this data. This is a CDC data from 2020, 2022 is something similar, and in 2024 we'll have the new set of data coming. But the thing is, if you look at the top 10 leading causes of death, 7 to 8 out of the top 10 leading causes of death are because of chronic metabolic illnesses. And what is striking is lifestyle changes play a very important role in prevention and in treatment of these chronic metabolic diseases. Why should I worry about it? As a physician, I do, because this is what it translates to: healthcare cost. Especially the obesity. 1 in 5 children and 1 in 3 adults are obese. United States is the only country where we use 16% of our GDP towards our healthcare expenditure. It's twice the amount of other developed nations, but the health indicators such as infant mortality rate, life expectancy, unmanaged diabetes, we do much worse than the developed other counterparts. So what is the disconnect over here? Why are we spending more, but our country is having more sicker patients and sicker population? So since I'm going to talk about nutrition and culinary medicine, this is why. A general consensus is the standard American diet. When we talk about standard American diet, most of the recommended daily intake comes in form of solid fats, saturated fats, added sugars, salt, and refined grains, not the whole grains, refined grains. And if you look at our 12 to 18-year-old, 40% of their calories come from these six sources: soda, fruit drinks, dairy desserts, grain desserts, pizza, and whole milk. And why is it important? Because, I'm sorry, I'm going to go back. And what is the missing food component in this? And since I'm a gastroenterologist, we are going to talk about fiber. Americans eat less than recommended amounts of vegetables, fruits, and whole grains. And what is the importance of fiber? And you've heard few of us, the prior speakers were talking about gut microbiome. And I'm going to just do two slides on gut microbiome to understand what's the buzz. Why is everybody talking about gut microbiome? What is there in gut microbiome? So the whole thing about gut microbiome comes from this research which is happening. This started in 2007, and it's across the United States through major institutions. It's called the Human Microbiome Project. And all the information that we are coming, the research that's coming out of it is what we talk about, or we hear the buzz about gut microbiome. So every one of us are born with a gut microbiome, and over the period of several years, all these factors influence our gut microbiome. If you see the genetics, where we are born, our mother's mode of delivery, and what kind of food or nutrition our mothers had, stress, diet, antibiotics. So there's so many things which go into our gut microbiome, and our gut microbiome works like in a symbiotic relationship. And whenever there's a change in that symbiosis, either by overgrowth of not good bacteria or loss of commensals or loss of diversity, is when we start seeing a lot of changes happening. Coming back to the nutrition, culinary medicine, and the fiber aspect, why are we interested in saying, hey, why don't you add more fiber? It's because of this, the short chain fatty acids. So just focus on this. Whenever we eat dietary fibers, what it does is the gut microbiome breaks it down into short chain fatty acids. And these short chain fatty acids are energy boosters for the gut colonocytes, keeping the gut healthier. So that's the reason why we keep saying. And the fiber, plant fibers are the only ones which the bacteria can act on to give the short chain fatty acids. No other dietary products can give rise to short chain fatty acids. And that's the importance of saying, hey, eat your rainbow, eat your fiber, add more fruits and vegetables to your diet. And not all fibers are made the same. You have to have a good mix of soluble fiber, insoluble fiber, adequate hydration to help regulate your bowel movements and constipation. That's a solely GI slide, nothing to do with nutrition. So why is it important? Why do we talk about lifestyle modification? We all know there's like modifiable risk factors and non-modifiable risk factors. And when we look at disease process, we would like to keep our population healthy. We would like to prevent diseases. So right from the primordial prevention to tertiary prevention, whereas primordial is our general population, we want to reduce risk. And tertiary is when a patient is already diagnosed with diabetes, has diabetic complications, has ended up with dialysis and so forth, and that is reducing the complications. So if you see, nutrition has a role in every single pathway of prevention. So that is the reason why we talk so much about nutrition and modifiable risk factors. So what next? Each one of us have had this patient encounter, whether we are covering patients in the hospital or we have patients who are coming to establish for wellness or have a diagnosis, and they ask us, doctor, what do we need to eat? And we immediately say, cut your salt, cut your sugar, maybe eat less carbs. And I put these all three together because the Mediterranean diet is well researched, well studied. This is the healthy eating plate from Harvard, and slightly changed up the CDC plate. And then we have the whole food plant-based diet, which is a buzz right now. But the common theme in all these plates or the pyramids is eating like primarily plant-based food and eating healthy fats, discourage use of saturated fats and trans fats, use herbs and spices to add flavor instead of salt, and not excessive alcohol, plenty of exercise, and this is very important, the connection of the social togetherness that we have sharing a meal. So going back to the patient interaction, we tell them, okay, go to the registered dietitian, and what next? We have all these diagnoses, half of them are interconnected, but we don't have answers. We don't know what to tell the patient. Should I completely stop eating fat because of pancreatitis? Should I cut down processed meat, red meat, because it's associated with cancer, is what I heard? Should I eat more fiber, less fiber? What about emulsifiers? There's so many questions and not many answers. And then we tell the patients to eat, the registered dietitian goes over and gives few resources, and the patient is like, are these food good for my health condition? And this is like very important. I don't know to cook because we live in a very fast world of processed food and fast food and drive-throughs. So half of us don't know, even if somebody hands me an eggplant, I don't know what to do with it. I don't know what else to go buy. So there's like a lot of things that we take it for granted, saying, hey, go eat healthy, but the patients don't know how to make those changes. And I think it resonates with us too, with me, because half of the time, if somebody tells me, go eat a Mediterranean diet, unless I know what a Mediterranean diet is, I would not be able to make those changes. So these are the unanswered questions that we have when we are trying to educate our patients to eat better or eat for their disease process. So what's the missing link? We all know in our medical training, there's only 25 hours of clinical medical training in terms of nutrition. If I translate that to days, it's just 1 day and an extra hour. And I can clearly say mostly it's spent on vitamins, minerals, learning about the deficiencies and how to figure that out in our step 1 and step 2. So that's pretty much what our basic training is. And that's where, and we kind of started understanding there's this big disparity between the health expenditure that's happening versus our patients are getting sicker, our population is getting sicker. What's the disconnect? Maybe it's the nutrition training, maybe we need to look at how we train our residents, we train our medical students in terms of nutrition. And that's when few medical schools started including culinary medicine as an elective. And when they started doing it, they started noticing that the trainees had hands-on exposure. The trainees had more in-depth knowledge about nutrition, and it kind of translated to patient care. So here we are, equally, I don't know what to tell the patient. Patient says, I don't know what to do, and that's where the culinary medicine comes in. It's a segue, everybody tends to say food as medicine. Yes, if you're healthy, but then, and as a preventative, but if somebody on a cardiac stent is on blood thinners, comes and says, hey doc, I want to be food as medicine, I would say no, it's food as an adjunct to whatever you need to be taking. Do not come off of medications without talking to your cardiologist, without talking to your endocrinologist, without talking to your primary care, because there's a reason why you're on the medication, and then simultaneously help them through to make changes for food as an adjunct to medicine. So what is culinary medicine? It's a new evidence-based medicine that blends medical nutrition along with culinary arts to help patients access and cook high-quality, delicious food, and at the same time have simple recipes. And the primary goal is to maintain health and to prevent and treat diseases. When we have culinary medicine curriculum, what happens is, along with the nutrition education, cooking skills, which are pretty basic, nobody wants to become a gourmet chef, it's like pretty basic cooking skills. Behavior change happens. when we go through the curriculum and we make the patients or the trainees to go through the classes, talk about medically tailored nutritional recipes and so forth, and over the period of time, behavior change happens, which is very important because when patients want to make changes, taking medications is okay, but habit and behavior has to simultaneously happen so that they can sustain the behavior change to help them with their nutritional goals. And the goal is to reduce nutrition-related diseases and healthcare costs. So you might ask why? Because with all the talk that we are doing, we are saying, let's go ahead and make these changes, but we are not giving the necessary tools for our medical residents as well as our patients at large how to make those changes. And culinary medicine bridges that gap. It helps patients with meal planning, shopping, storage, food wastage. That's an entire topic on its own, food wastage, budgeting and cooking, and as I mentioned, behavior changes too. So how do we know it works is because when these medical schools adapted the culinary medicine curriculum, what happened was they did surveys prior to the curriculum versus after a couple of classes of culinary medicine, and the residents and the medical students before going into these curriculum did not have the confidence or did not have the knowledge to counsel their patients. Once they started learning hands-on, they were able to better communicate to their patients in counseling as to what needs to be done for changes with the nutrition. And the same way, whenever there was this particular study which showed that there were two cohorts of patients, and pre-diabetics and diabetics, and one cohort was given resources and recipes for Mediterranean diet, and the other cohort, they had hands-on cooking classes. So at the end of 6 to 8 weeks, the ones that had hands-on cooking classes did much better with all the parameters, and also the behavior change trickled down to few more years after the classes were done. So that's something interesting, because when you give them the tools, when you cook along with the patient tends to understand why they need to make the changes, how to make the changes. So why should physicians care? And I think equally, just as our patients, we all struggle with what we need to eat, how to balance meals. Is this the right one? Somebody says intermittent fasting is good. Somebody says keto is good. I need to lose weight. We struggle with that too. So as physicians, as much as the patients struggle, we need answers too. So why do the physicians care? Because nutrition is a gateway to healthy lifestyle. We care for our patients and for nourishing our bodies. So there are so many questions. It's nice to talk about, hey, let's get together, let's cook and so forth, but there are so many barriers to get this going. There are barriers on the patient's aspect, and there are barriers on the physician and the system aspect. So when we look at barriers from the patient aspect, we have food insecurities, food deserts, resources, and cultural barriers. As I mentioned, I can't go to a Southeast Asian and say, try a Mediterranean diet, or I can go and tell a farmer or a rancher, try a Mediterranean diet, who have never heard about Mediterranean diet. So cultural barriers, awareness, and from the system aspect, getting the physicians and patients on board, knowledge, logistics, teaching kitchen facilities, community partnering, and group visits and billing. So for group visits and billing, we can still do 99213 or 99214. And if you're not spending time and you're using a registered dietitian, the billing would not come under you. So that is American College of Lifestyle Medicine, as well as there's another group which has coding related sheets for culinary medicine group classes. So knowledge pathway. Science is evolving, medicine is evolving, nutrition is evolving, and the good thing is we can learn to adapt. whatever nutrition training we've had before, whatever it is in evidence, is this, we have a pre-existing knowledge, and we also have a new information that it's not working for us right now. It's not working for us to help our patients, to help with their health and disease process. So when the new information comes in, we unlearn what we have learned before, and we try to get new resources and support, relearn, which is what we are trying to do for the culinary medicine, and then reinforcement and update. So we just go through this pathway whenever new evidence comes. So here we are educating the healthcare professionals, providing the information. We provide information for online resources, and once we think, hey, culinary medicine is something that we can look into to help our patients, then we set up what needs to be done, group visits and so forth, and that's the way we break down the barriers. So culinary medicine set up physician-led team, registered dietitian, trained chef, volunteers, that could be patients, that could be our residents, teaching kitchen, partnering with community food sources such as farms, community stores such as Walmart or HEB, and drawing up a curriculum. The best thing about culinary medicine is you can draw up a curriculum for your mast cell patients. You can draw up a curriculum for your diabetic patients. So it just doesn't have to be hard and fast, or you can just draw a curriculum for wellness patients. So it's very nice to work and create a curriculum for your practice model. So this is the teaching kitchen in action, and these are our residents. This is Dr. Ali Beshek. When she was a second year resident, she started the culinary medicine classes as an outside 2 to 3 hours at the end of the day, and she partnered with the chef, and what they do is they pick 2 to 3 dishes where they learn to cook, they learn to know what spices go in, knowledge with cooking skills and knife skills, and pick up a couple of nutrition articles, and they cook together. And it's more like a bonding and wellness, and at the same time, they are learning how to teach how nutrition can be made as an adjunct to medicine, and that they bring that back to their patients. And this is one of the cooking event along with our community for colon cancer awareness. And we did a cooking, this was our chef, and we said, hey, we need to focus on plant fiber, how to make simple recipes with plant fiber, how to incorporate it. And then we had a huge meal at the end and question and answer session. So it's pretty nice, and patients tend to like that, and so do the residents and the fellows. I'm going to skip that. And these are the other resources. If you're interested in culinary medicine, there is Health Meets Food, and they have virtual as well as hands-on certification course, and close to more than 55 medical schools have adapted their culinary curriculum. And then you have the ACLM, which is the American College of Lifestyle Medicine. They also have a curriculum for which Dr. Michelle Hauser has, like, she kind of put together a whole bunch of lifestyle medicine culinary curriculum, and that can be adapted. Then we have this Healthy Kitchen, Healthy Lives. This is a Harvard-sponsored event which happens annually in Napa Valley, and they do it in collaboration with Culinary Institute of America, and it's like all professionally trained chefs, and they teach you how to put together simple meals, nutritious meals, and there's a lot of back and forth of knowledge sharing of healthy cooking. And then you have the Culinary Connections, which is one of the columns in ACG magazine, where the gastroenterologist and all the others contribute their healthy recipes, and it's a way of like helping each other. So that, and in the world of culinary medicine, I just want to point out to Dr. Shui. She is an internist, but also a professionally trained chef, and she does culinary classes for medical trainees as well as for the patients in the community. And also she has published a book. It's more like what I call flexitarian, with more plant-based meals put together. So, and okay, and then you have Dr. Jacqueline Albin. She is in Dallas, and she has been doing amazing in the world of culinary medicine and the curriculum, focusing on pediatric age group food deserts and food insecurity. So she is somebody that if anybody is interested can reach out to, and they have good amount of information on culinary medicine. And some of the systems are moving more towards farm to table or like partnering with the local farms to bring in their produce and trying to move away from fast foods or the kind of foods that are served in the hospital when patients are recovering. And this is Augusta Health in Virginia, where they've partnered with a local farm and they have a teaching kitchen. So the residents and the fellows actually rotate through as an elective to know where the foods are coming and also get a elective in culinary medicine. So what does the future hold? It's an integrated lifestyle. This is more for a gastroenterology practice, but it can be adapted to any kind of practice. Integrated lifestyle practice model, where you have the physicians, you focus on the pillars of lifestyle medicine, sleep, stress, mental health, nutrition, physical activity, and health coaches. And what does more into the future, this is very futuristic, where NIH is has launched the largest precision nutrition research, where the nutrition would be geared to an individual. Is it there yet? No. Would it be here in the next 10 to 15 years? Maybe so. But right now what we have is culinary medicine in our hands that we can effectively use to help our patients. And with that, I end my lecture.
That was an excellent kind of landscape of culinary medicine. We enjoyed it. So open for questions.
Yeah, it was an excellent presentation. Thank you. And my question is, as a private practice physicians or like practicing outside, so how do you incorporate the culinary medicine into the practice? Are you worried about the food safety, like when you are providing the food or like cooking with them or doing the demos? What are the rules around food safety? And second question, if you do have a dietitian or someone, how do you incorporate these codes into providing these services or is there good reimbursements for that?
So the reimbursement, it's more like a group visit, so it depends upon, I don't do like culinary classes for the patients or group visits. So what I would say is I can get you the information, but it's more of time-based. As long as a physician that you are there trying to interact with the patients, you can break it down as a 99213 and make it as a group and as how many minutes that you can bill it instead of the what you call as a level of difficulty. Instead of that, you can do time-based.
Hi, my name is Dr. Sunil Tumala. I'm a practicing neurologist and a yoga instructor, and I'm also an avid reader in Ayurveda. So some of the talks today, we vilified dairy products. And in Ayurveda, there is a lot of emphasis on dairy products, particularly the fermented versus non-fermented. So do you have any information on fermented dairy products being better than unfermented?
Okay, so this is what I would say. I know there's a lot that goes with dairy and non-dairy, and there's a lot of research coming. As a person who talks about culinary medicine, food, and nutrition, I tend to tell my patients each person is unique with the way that they react to food. And there is no food that is bad unless there is a documented allergy. So any patient who says, hey, is dairy bad for me? No food is bad on a limited, in a small doses. When I pointed out dairy as a cause of empty calories is when we substitute water, we substitute milk for water as a source of hydration in young children, which is like, hey, you're thirsty, drink milk. Hey, you're hungry, drink milk. That's like a lot of milk. Nobody requires that much of milk, where you're actually substituting and overdoing milk. Fermented, yes, because of the probiotic nature of it, but I wouldn't say no to any kind of food unless somebody is really allergic to the food. Everything in moderation and see how your body reacts to it. Question here?
Just another question.
Yes.
What do you think about, again, in line with the question that was previously asked, about the fermented food products such as kimchi, sourdough bread versus other products? And then the other question is, what do you think about, what's your take on things like Factor-X diet or keto diets that are delivered to your home?
So foods that are delivered to home, balanced food. I am a very big proponent of plant fibers. So if you're a busy person and you feel that cooking is not your thing, putting together is not your thing, but you have you can fall back on delivery services, you can fall back on HelloFresh and all those prepackaged meals. As long as you know that you're receiving a balanced meal of carbohydrate, protein, a little bit of good fat and fiber, why not? Keto, again, keto in terms of just meat or carnivore keto is good for short-term weight loss and getting your parameters under control, but for gut health, it's something that is not sustainable. Again, as long as you try to do keto, which includes plants and plant fibers, so that you can get that prebiotic and you can get that gut microbiome going, it's good. But I just a carnivore keto is not something that's good for gut.
Vani, here question. Vani,
Yes.
it's a very good talk. I know nowadays everything is social media driven. Is there any specific influencer or someone you would recommend in terms of Instagram or TikTok? You know, we do see, I follow a couple. I follow you on Instagram where you do influence a lot about healthy, cooking, gardening skills. And there's another doctor, Dr. Monica, who's really great. So is there anything in particular you would recommend for patients? Of course, without any bias. Specifically social media driven influencers.
So social media is a rabbit hole. It feeds you what algorithm it goes by. So I would say look for the credentials of the person who's posting information, whether it's coming from a certified registered dietitian, a certified somebody from the medical professional who has the expertise. That's number one, which also doesn't mean that some of them might not be following evidence-based medicine. So once you know the credentials are okay, if in doubt, always reach out to your primary care doctor. Reach out to somebody who you can actually talk and ask, hey, I saw this on TikTok. Is this something that we can, go ahead and get done with it, or can I follow it? Because some of the medical professionals, just because of the social media, might not be providing evidence-based medicine. So if it is harmless, yes, but if it's anything related to health, any fad diet, any new product or any supplements that they are trying to push, I will always take a step back and I'm like, okay, I should talk about this with my primary care or send that my chat message real quick. Hey, it's all about this. What do you think? Is how I would go. I would not just blindly follow an social media influencer or celebrity who calls themselves as influencers. So, health experts. No. That's my take on it.
Thank you.